Hi, everyone. Good morning or good afternoon, depending on where you are. My name is Tara Kalk. I am the program manager for the Southeast Mental Health Technology Transfer Center School Mental Health Initiative. And we're very excited for today's learning session about opportunities and solutions to implement measurement-based care for more personalized, collaborative, and effective school mental health interventions. I invite everyone to turn on your camera, but keep yourself muted while Dr. Elizabeth Connors is presenting. But we would love to see all of your beautiful faces, and feel free to use the chat box to ask any questions or share any resources that you might want to share with other attendees. And if you have any audio or technical issues during the session, you can also reach out to me or Sarah Trello from the Southeast MHTTC, and we can assist you. And a little disclaimer before we get started. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. And a quick introduction. If you don't know about us already, today's session is brought to you by the Southeast Mental Health Technology Transfer Center, or MHTTC for short, and the School Mental Health Initiative specifically. We are located in Atlanta, Georgia at the Emory University Rollins School of Public Health, and we're proud to serve 8 states in HHS Region 4 that you see pictured here in blue. Our center includes faculty and staff with expertise in public health programs, finance, policy, and health systems, which provides us with a unique lens through which we can address mental health priorities in our region. The goal of our center is to accelerate the adoption of evidence-based mental health programs and practices by providing training and technical assistance to Region 4. On the next slide, you see there is a screenshot of our website. You can go there to www.southeastmhttc.org and view upcoming trainings, as well as archived recordings of our past trainings and a whole assortment of resources, including infographics and courses. And I think Sarah can plop that link into the chat box right now. And then without further ado, I'd love to introduce Dr. Elizabeth Connors. She is an assistant professor at Yale University and a faculty member with the University of Maryland National Center for School Mental Health. Dr. Connors received her PhD in clinical child and community psychology, and her work focuses on improving access to high-quality mental health promotion, prevention, and intervention services and supports for underserved youth and their families in critical access points such as schools and community settings. And I'll hand it over to you, Elizabeth.
Great, thank you so much, Tara. I'm so excited to be here with all of you. And please, if you haven't already, type your name and your organization and your state into the chat. I've seen some people already starting that, and it's just great to see everyone who is on with us today. We've had a really nice response to this webinar, and so we're excited that you all are able to come on. I want to reiterate what Tara said. Please feel free to turn your cameras on. I saw at least one person with her camera on outside while she's getting some fresh air, and I love to see that. I think we need to stay creative in terms of how we can stay connected and stay engaged in this sort of virtual training environment world. So welcome to those of you who are here from the Southeast, as well as people who may be here from outside the Southeast. We know we sometimes have people joining us from all over the country as part of the MHTTC network, and so we welcome you here. So here's what we're hoping to do today. This is a part 2 of an initial MBC webinar that we did in the fall, which I have a link for you coming up. If you happen to miss it, or if you want to refresh or share it with colleagues, we'll make sure that you have the part one. And today we're really going to dive into a little bit of a deeper understanding of measurement-based care implementation, as well as make sure that we're really increasing our familiarity with free or low cost measure options, as well as best practices in training and implementation support, specifically of school professionals, and really thinking about the school context as a unique place to implement this practice, and relying on our cross-state networking and shared learning that we have here and the shared wisdom of you all to really help kind of elevate our understanding of what it takes and what it could take to implement MBC in schools. So our plan for today is, I do want to start us out with just a real quick definition of MBC, just to remind us all about what this practice is, but we're not going to spend a lot of time in the background. I'm going to direct you to the part one of this training for that. And then we're going to dive into some MBC implementation barriers and solutions. Those of folks who joined us for part one actually gave fantastic feedback and questions, not only during the webinar, but also in the evaluations, about additional information that you wanted. And so we've developed this agenda specifically around questions that arose from part one. And this is why we value your time always and feedback to let us know in those evaluations what else you need. I know that the Southeast MHTTC is really dedicated to being responsive to, what you all need in the field. And so we were glad to be able to craft this agenda today in response to that. So many of you told us that you wanted more concrete information on how to engage students and parents in this practice, wanted to really go over some free or low cost measures again, and how you can search and find those, as well as evaluating some data system options. We have a list of examples for you, so hopefully that will reduce your homework time as you're looking for data system examples, and then really planning ahead for training and support. So talking about some implementation strategies that you can use. And then at the end, we have some bite-sized steps to get started. So hopefully you'll leave today with some clear directions and ways that you can get started, implementing this practice and supporting this practice in your system. That's not going to feel like too heavy of a lift. All of you have such busy jobs already, and you may be coming to this topic with a lot of interest and enthusiasm, but maybe not a whole lot of extra time in your life. So we are going to end the webinar with some bite-sized next steps to get started. For those of you who are available for the 30 minutes following the webinar, we are actually going to stay on and have a more informal discussion with folks about, what else you might need, what additional questions you have. We can talk a little bit more about barriers and solutions. We're very interested in hearing if people want individual or group consultation on this, or follow-up webinars. So we will be on for the 30 minutes after the webinar for anyone who's interested and willing to stay on. And we're just going to facilitate an informal conversation. So hopefully folks can stay on with us. If this is really something you want to dive deeper into, and you're curious about how the Southeast MHTTC could support you with training and consultation, please stay on with us at the top of the hour. Okay, so let's just revisit what we mean when we are referring to measurement-based care. We are referring to the routine collection and use of client-reported progress measures throughout treatment to guide clinical decision-making. So routine collection means that we are doing this on a regular basis with students and families. That could be every session, that could be every other session. It might be monthly, but we're not talking about twice a year, and we're not talking about even really quarterly. So really, to be within this MBC definition, we're talking about very regular, brief sort of data collection and use in the moment. And I mentioned those other examples because often in schools we'll do like a beginning of the school year, mid-school year, and end of school year check-in, and checking into student progress in those ways are wonderful. But when we're talking about MBC specifically, the practice that we're really trying to push the envelope on is how can we collect and use these measures on a more frequent basis. And we want to just not just collect them, but use them, right? So throughout the intervention process to really guide our decision making with the student, with the family about to what extent is what we're doing working, or might we need to change some things up? So really getting away from any data black holes and really using those data in the moment, asking students and families to explain and contextualize that information, and then have kind of a shared decision-making process about how do we understand how this intervention is fitting with the student. So for those of you who probably work on a lot of different types of services and supports in schools, from universal mental health promotion to kind of early intervention tier 2 and more indicated treatment services at tier 3, we could use measurement-based care in kind of the tier 2 and tier 3 realm. So we're really talking about those upper ends of the triangle, so to speak, when students are receiving individualized services, but this is also a practice that can be used in your group services as well. And there's some good foundational work being done for MBC and groups. And so last time we went into a little bit more detail about the components of measurement-based care. And to me, this is kind of the clearest way to explain what the practice includes. It includes collecting a very brief, either student-reported, parent-reported, teacher-reported measure, sharing those data as soon as possible, hopefully immediately, with whoever reported it to you, and having a conversation in that sharing about what the data mean, and then taking some action on that. And whether that is that we're going to stay the course, or we need to go slower or faster, or you need a different kind of service, or we're moving you towards sort of graduation because you're gaining a lot of skills, or hey, we need to loop in mom a little bit more because of this issue that's come. There's so many different ways that we could, quote, act on the data depending on what we learn. But MBC really involves all of these elements: collect, share, and act. These elements are reflected in a lot of work that's been developed through the Veterans Healthcare Association. You can see some of the citations here. There's actually even a citation that just came out recently, really detailing the Collect, Share, Act model. So this has been implemented nationwide within our VA healthcare system and has gained a lot of traction that way. And this particular model of MBC is very practice oriented and really communicates how people who are practitioners with clients can do this work. So I encourage you to look into the Collect, Share, Act model, and I have tons of other references and websites and things like that that you can go to if you want more info on this. There's a lot of different ways that MBC kind of looks in schools, and it doesn't always go by this word. And so I'm going to ask you all in a minute to share with me what other words you use to describe MBC. But just know that there are some vignettes here if you want to look at them and kind of reorient to, you know, the types of things that we would use MBC for. You can see in some of these examples that we're using a student or parent or teacher reported measure to confirm a diagnosis, and then we're having some sort of weekly or regular discussion and review of some brief elements. It could be a couple of items that are pulled out of that initial assessment. It could be a shorter assessment. It could be something that we're creating with the student just for them, like you know, a coping skills tracker, or, you know, looking at, you know, homework completion, or looking at attendance. So really thinking about students in both general education and special education who need some sort of individualized service. How can we use some assessment tools to understand what the need is up front, but then also keep checking in on that over time to make sure that we're kind of checking our work along the way and making adjustments. I do want to note, and I'm probably preaching to the choir here because you all sign on because you're interested in this topic, but MBC really does have the opportunity to improve school mental health quality and sustainability. And so I have this here for you in case this is something that you need to message to your colleagues about. Why would we want to take on this practice? And it's not just about data collection and showing outcomes for outcome's sake, right? So MBC as a practice really takes us beyond that. It helps us promote services and support services where empowerment and student and family voice is at the center of what we do, where we are intentionally involving students and families in their own interventions in schools. It's helping us as school mental health providers be really transparent about what we're doing with young people and why. What are our goals? How are we evaluating progress? And it allows us to share that information very clearly with students and families, so there's no confusion about what it is that we're doing, why we're doing it. And then this has actually been said to be an element that can reduce mental health stigma, because services become sort of less mysterious or less of a black box. And it also does drive some accountability, I think, for us as providers to really document and communicate what our goals are and how we can measure progress. So it does hold our feet to the fire a little bit, as well as ensuring interventions are data driven, so it can promote effectiveness of our tier 2 and tier 3 services, and over time really does buoy sustainability, so that we can track and communicate the impact of your tier 2 and tier 3 interventions eventually. We know we've got to get this practice off the ground first, right? And you may be starting with a small group of willing clinicians, figuring out your data systems and scaling it up. But once this is something that has gone to scale, it really can bring you a lot of helpful data to advocate for continued funding and staffing for school mental health. I shared an example on the part 1 of a school district that has brought this to great scale, and they have really awesome outcomes in being able to show the effectiveness of their tier 2 and tier 3 services. And there are a number of districts that I'm familiar with, large districts even across different parts of the United States, who have brought this to scale, and it's helped with their sustainability. But please know that although that may be part of your end game, that's not where we're starting. We really want to start with understanding and supporting this practice as something that clinicians do for and with students and families, and that this is something we do for transparency, empowerment, and effectiveness. So I do want to ask, I've been using this acronym MBC and really describe what it is. I'm curious about what synonyms or related terms and practices come up in your languages in schools to describe this, because you may or may not use the term measurement-based care with your teams. So feel free to type in the chat. What else do you call this? Perfect. Progress monitoring, Lindsay shared. Excellent. The piece I would add to that, Lindsay, if you're in a space that talks a lot about progress monitoring, I would add and feedback. So progress monitoring and feedback. So that may be a good way to make, because sometimes with progress monitoring, we collect data. We don't always do the feedback loop, but yes, absolutely. Other terms, what else do you call this practice? Oh, a problem-solving team. I love that, Robbie. Yes, so if you might have certain teams that particularly would appreciate this practice because it can enhance their problem solving and really understanding what's working, what's not working, and what to do next. Data-driven intervention. Thank you, Miriam. Data-driven intervention. Sometimes we say data-driven decision-making. Absolutely. Growth measurement. That's a new one. I haven't heard that. I love hearing new terms. Yes, growth measurement is a good one. A term that's a little bit old school now that shows up in the special ed literature for you special ed educators out there is goal attainment scaling. Another one that comes up a lot is response to intervention. I don't know if folks are in settings that are really steeped in RTI type of language or even MTSS type of language. Some of that shows up on the academic side, but we can borrow those terms to talk about how to support student psychosocial interventions. I encourage you to use language that is endogenous to your systems. If it feels like an ill fit to start using this other term, MBC, I would not recommend forcing that. I think we need to work within sort of the language and the values of the systems that we're in, but making sure that it includes these components of MBC that I talked about, that we're moving beyond just data collection, we're really sharing and acting on the information, and that we're doing that with students and families, not for students and families. So as long as you can kind of layer in those components and make sure they're represented, you know, those may be the growing edges of the terms or the practices you're already using, but absolutely use whatever terms make sense, because that's how we can promote alignment, right? You don't want to bring in a whole nother thing. That's not helpful. That stresses people out. But there may be ways to improve the quality and sustainability of what you're doing. And so to promote alignment, let's use the terms that make sense in your system. And then you can be kind of the change makers to say, hey, we're collecting all these data, but to what extent are we really involving families, for example? Can they be part of you know, the team meeting on their students? So really just pushing the envelope on quality, but not necessarily having to bring another term if it's not a good fit. Collaborative problem solving, excellent. Thanks, Prudence. So if you do want to review the MBC Part 1 slides and recording from November 4th, we have the link right here, and I know it's in the chat as well, so feel free to do that. Sarah just put that in. Great. So let's talk a little about engaging students and parents in this practice. Please know that in the broader MBC literature, that there are pretty clear data. When we use MBC as compared to sort of usual care practices that don't have this component, the services with MBC have been found to improve patient-provider communication and working alliance, as well as retention and treatment, so staying in services longer. I know in schools that's not always our biggest problem, because we know that young people stay in services longer in schools as compared to clinic-based services. But the working alliance and that kind of communication with families, I find, is particularly relevant for school-based mental health services, as well as the client's sense of involvement in therapy. So we want the students to feel involved, we want the families to feel involved, and we want them to know how important and central they are to the success of whatever they're working on in their interventions. Another thing that's come up in the research literature is that clients actually report kind of a better attunement to their own symptoms. So being able to kind of recognize and be attuned to what's going on for themselves and when things are going better or worse. I know particularly working with children, we're often really trying to promote this, right? Whether it's emotion recognition of self and others, or being able to have some insight into, you know, how they're doing week to week, increasing that attunement to kind of their own progress is often something we're working on. So MBC can be a great tool for that. So if we had an easy button, we might think that engaging students and parents is pretty easy in this process, but we had a lot of questions come up about engagement in MBC after our last webinar. And so I just want to invite barriers that you have encountered when trying to involve students and parents in school mental health services generally. What are some of the things that come up that you feel like you're kind of up against? Great, good ones coming in. Trust, communication, and time are the first ones to come through. Yes, absolutely. Lack of awareness about mental health resources. Yes, thank you. And sometimes we refer to that as like mental health literacy. So like, and can be related to stigma, but can also be practical. Like they might just not know how to connect to mental health resources or what to do when they're connected. Lack of follow through, and that could be, right, ability also to follow through. And so Robbie is acknowledging that there are a lot of things that go into that follow through process after we've maybe referred or recommended a connection or service. Lack of interest. So a lot of times in schools, students may be referred by their teacher, for example, and the family may not be as attuned to some of the needs. And so when we reach out to the family about services, they're like, I was not aware this was an issue. So sometimes it does feel like there's not as much interest. Schedules, yes, oh my gosh, schedules and time, a lot of moving parts to coordinate, absolutely. Stereotype and stigma of mental health services. teamwork, judgment, and family feeling shame. So a lot of centering voices from traditionally marginalized communities. Thank you. You know what, one of the things I can tell, this is a very astute group because many of these are what we would consider to be perceptual barriers to treatment, right? Like stigma and awareness and sense of trust and sort of how relevant treatment is perceived to be for the family or how needed that is. Might also be around sort of cultural beliefs of what we do when a student's facing difficulty and what are the best ways to address and support that. And our sort of traditional mental health treatment services may not be aligned with family beliefs. And so there are practical barriers like timing and teamwork and all that stuff for sure. But a lot of times the engagement barriers we see can be more perceptual and based on the relationship and sort of making sure that we're being culturally and linguistically competent and family centered in our work. Miriam added maybe misperception or miscommunication that mental health is intended to, quote, fix a student apart from caregiver involvement or to get a student to fit the mainstream, which could be a too rigid approach. So yes, absolutely. And so understanding these potential barriers to engagement is really an important process to be able to promote engagement and retention in services. And MBC, and I'm going to share a few engagement strategies, but MBC is actually a pathway and a tool that you can use to tackle a lot of these perceptual barriers to really center student and family voice, communicate their importance of, the importance of therapy to them and that it is going to be individualized to their preferences. Okay, so here's a few strategies to think through, specifically related to MBC that could help you with engagement. The first is explain the purpose. Okay, so when you're kind of doing your rationale and your spiel about, we are going to work together to track you or your students' progress over time to see what's working and what's not working. You want to provide a developmentally appropriate explanation. Things like there's no right or wrong answers. And this helps us talk about how you feel, how counseling is going for you, and if we need to change it up. So, the student and family need to get the message that this is actually a way for you to let us know how things are going and to use your voice, because your voice and your experience of progress is actually the most important piece of information that we have to understand how these interventions are going. We do want to have as many reporters as possible, especially for children and adolescents. We know this just from general child clinical therapy work is that, we need to kind of be able to triangulate different reporters or respondents or perspectives. So please strive for having multiple reporters. You may start with the student or start with the parent, but really optimally, getting different perspectives and talking about those discrepancies is an important part of the sort of therapeutic process. And let them know what to expect, right? So manage some expectations, right? This isn't a test. We're not expecting that things are going to get better and better every single week. And if it's not, that you're in trouble or you're not doing something right or we're not doing something right, but rather there's going to be ups and downs, right? We're here working together because some things have been hard for you at school or at home or et cetera, whatever the purpose is of the intervention. And it's very normal to have ups and downs across the school year. Whether you're receiving intervention services or not, right? We all have ups and downs over the course of our life. So if we're doing kind of a weekly or every other week progress measure, it's not going to look up and up and up. But over time, that's what we're hoping, is that there's over time some ups and downs, but looks like an upward trajectory or some kind of stabilization. So just kind of giving them a heads up about what to expect. And if you're using a measure that is standardized and norm referenced, please let the student and parent know that their responses might be different from those who the norms were developed with. So sometimes the samples that were used to norm these standardized measures were based on, certain ages at certain grade levels. There might be binary genders that, the norms are based on being a boy or a girl, or other sort of cultural differences. The strengths and difficulties questionnaire, for example, was normed on a European sample. And so just understanding a little bit more about the measures you're using and letting them know that what that sort of quote clinical cutoff is, or what those cutoffs are, those are just guidelines, and those may not have been developed with children who were like them. So we need to just be really mindful about what norms and cutoffs tell us, and what their shortcomings might be. And that ultimately the student is an individual, and we need to really understand their individual scores. And to let them know that we need their help to understand what the data mean for them and their student. Sometimes when we take these measures, we think that there's going to be some magic happens where it unveils some sort of truth, and based on what we check off. But the reality is we need to understand from the student and family perspective how to understand, why did you mark this sometimes? When was this happening for you in the last 2 weeks? When wasn't it? Help me understand that. And so the truth, so to speak, of what's happening with the progress lies in between how they complete the measure and then what they share with you about why they completed it that way. You always want to cover where data will be stored and confidentiality, of course. And if you want an example, and actually we can make sure that you all get this because I know it's a small screenshot. This is something I've done in trainings where we have like this rationale Mad Lib where you can kind of fill in the blanks and build your way to explain your purpose to students and families. So this would be all the types of things that you would want to cover. And I have tons of other scripts and things like that, and guidelines. But you really want to get this piece down, is explaining the purpose and why we're doing this, so they know up front, this isn't a research project. This isn't to evaluate my student. This is really so that we can make decisions together, and my voice and experience of progress can be part of what's being done. You might have to revisit this rationale a few times throughout the school year, because it may not be what people expect when you hand them a form to fill out. Okay, so just realize that this might be kind of new to people. We do want to make responding fun and easy, make sure students know how to respond, give different options. I think working with parents in schools, we always need to be able to do stuff over the phone, in my perspective, like how can we ask them these questions over the phone if they can't come in, or how can we get them electronic version that's mobile friendly and they can do on their phone during their lunch break, but just making sure there's options for completing this. And providing visuals for response options is really helpful, and helping them practice. So by asking their feedback on something else, like, let's practice how we would use this scale. What's like a thumbs up, what's a thumbs down, and what's something in the middle. How tasty was your dinner last night or your breakfast this morning? Or how hard was your math homework? And really just, especially for our younger students, they might need a little bit of practice with some feelings faces that get attached to how to respond to these things. I've also seen clinicians do like glasses, like a glass of milk, like all the way full, like halfway full, or empty. I've also seen clinicians put things on calendars, like, let's talk about what's been going on in your life for the past 2 weeks. Okay, now let's talk about, how have your anxiety and your worries been when those things were going on. So just allow yourself to be flexible and make sure students understand how to respond. You're orienting them to that. You don't have to stick to just those words of strongly agree and strongly disagree. You don't want to make it aversive. You don't want to make it an experience where it feels like it's some sort of test that their brain has to work really hard to understand the words. And if it's not understandable, or if it's too developmentally advanced, then take the words out and just use the feeling faces, or, come up with a way, because the point is you just want their feedback and you want them to be able to engage in a way that feels developmentally appropriate for them. I think sometimes we feel very constrained by our assessments, and we're trained to do them with a lot of administration validity, but ultimately we need the student and the parent to be able to engage and understand the process to give valid answers. So be creative and make it fun. And then the third engagement strategy is not an exhaustive list, but absolutely sharing and using the data. I know that I am so much more likely to fill something out the next time if you told me or we talked about what we learned last time, right? So we all have things in our job where we have to report out or enter data or, document what we're doing. And there's not always feedback loops to us about why that's needed, what's learned. People aren't necessarily asking us to contextualize that information. And so the same goes for students and families. We need to share and use these data, and immediately if possible. I'm curious if folks have ways that they currently share progress data with students and families. So if you want to, feel free to share aloud or type that into the chat, things that are either working or not working around this. How do you currently share progress data with students and families? Or if not, why not, and what gets in the way? This is not always our routine in schools, for a lot of the good reasons that were mentioned before, time being one of them. So Kimberly shared that she feels like much of the time we're responding to the situation in the moment. Absolutely. This is a very proactive strategy that I'm talking about here, right? So this is kind of getting us in those moments where we're not immediately in crisis mode, or helping us put on the brakes when we do a session and it feels like it needs to be taken over by sort of the crisis of the week. This is one of those practices that helps us slow down and be proactive in terms of monitoring progress. So that's definitely attention, especially some of you may be in roles where you have more sort of crisis response or de-escalation as part of your role. And I think that varies by schools that we're in as well. Sometimes schools have different expectations about what our roles are as the mental health support. So that can be really tough sometimes to put in these proactive progress monitoring practices. Progress reports, absolutely. That's progress reports is, I'm so glad you brought that up, Bonnie, because that is a feedback loop that is sort of institutionalized in schools, that parents get progress reports, right? So thinking about that as a parallel, how can we have more progress report type of functions and features with our tier 2 and tier 3 services that are being provided? Sometimes families and students may not understand the progress data, or we may not understand the progress data. So that kind of goes back to transparency and making sure that what we're set up is kind of understood by everybody. And we can kind of head some of that off at the pass by doing a little bit of the work on the front end. It also can be hard if you're sort of told to monitor progress in a certain way that might not fit what the student really needs in terms of progress monitoring. So some of you may have requirements to monitor certain things for all of the students, but that may or may not be a good fit for why they're in interventions with you. This sometimes happens for our special education students where there are goals, for example, on the IEP, and that may not feel totally reflective of what the student needs right now this school year. So you have to sort of document IEP stuff, and that it can be very challenging to figure out how to do measurement-based care within that, but there are solutions. Phone and mail, thank you, and monthly parent check-ins. I love that, Deanna. I love that you're having monthly parent check-ins. And again, that's something that you can set up as an expectation at the very beginning. And so, some of you may be thinking about what pieces of this you could implement this school year, but I also want you to be thinking about what you could implement when the school year comes back. So what conversations do we have with families at the very beginning, when they're referred, when we kind of have that moment of setting expectations for how we're going to work together, how often we're meeting with families, who's involved in setting the goals and how we're going to monitor progress. A lot of these conversations are more natural at the beginning of services, but there's always time for a reset. And I think particularly if you have students who are struggling or not really responding to interventions, it's a great time to say, hey, let's do a reset, check in on our goals. We want to make sure we're having monthly parent check-ins, for example, and collecting some progress data so that we can kind of all get on the same page. Miriam shared that sometimes clinicians are uncomfortable sharing behavioral health data with the student only. And some of us have been trained to treat kids and caregivers as the client unit if the parents are not physically present. Right, so there may be worries about liability and sharing with youth only. Yes, so this is a very good point. So, you know, I would recommend that this be something that you all talk about as your team. Like, what are your policies and procedures? What are people's comfort levels? And how can you set up what's shared with the parent and what's shared with the student at the beginning, right? So you might be having a lot of student-centered sessions where data collection and sharing and feedback is part of your regular practice with students. And then it may be a monthly interval, parents are part of that. Or maybe then you're calling the parent to check in. There's a lot of different ways to address this, but I think really thinking critically about why we do or don't share with parents or students. What are some of the concerns and constraints? Maybe it's our training, maybe it's our liability, maybe it's just our status quo, and that's the way we've always done that. This is a good time to start kind of poking holes in some of those, because that's how we make quality improvements, right? Is to recognize that there may be a mismatch between sort of the best practices and the usual practices, and how we move toward those best practices is by tackling exactly some of the things that Miriam put in. So thank you for sharing that. So a couple quick tips on share, and then I want to talk about where you can find measures, because people always want to know about that. So basically what I mean when I say share the data is that we're reporting it back to the student and parent. You might need to provide a little education on the score, the measure, the individual items. Always ask if it matches their subjective experience. How does it fit with how they feel things are going? If there are discrepancies, like the parent and the student have different perspectives, discuss that. That is a great moment for a conversation, acknowledging if they're on different pages, why that is, and how we can either try to find common ground, or how we, how we sort of deal with that from a clinical standpoint. Discrepancies are good information. We should not shy away from discrepancies. We should capture and acknowledge discrepancies, and acknowledge that it's normal for parents and students to have different perspectives on how much of a problem something is or why something's happening. And then please try to document that you're collecting these things and you're sharing these in your notes. And I know that looks different for everybody. So we do want to, in terms of a little bit of how to, I want to include this. So you can show or tell the scores over the phone, in person, or if you're doing telework and you want to review individual items and total scores, what they mean, and a visual graph. This can literally be done in like 3 sentences, super quick. And I actually have, I can share with you at the end, I have some links to some little demonstration videos that show how you could do this. And you don't have to have an electronic system, by the way. I've done a lot of measurement-based care work where, they fill out the measure, you kind of do a quick tally and score, you compare it to what they told you last time, and you have a conversation about it. Individual items that have shifted, overall scores that have shifted, talk about whether it's higher or lower than last time you met and why, and what that means. Do you guys want to keep staying on the course that you're going on, or is there something else that would be useful to talk about today or bring into the intervention? We always want to ask open-ended questions. Don't tell too much. Ask, what are your thoughts about this score? How does this score compare to how you're feeling? How does this match with where you hoped we'd be right now? So ask open-ended questions so they can really share with you some information about why they filled out things they did and how they're feeling. And then here's where we just use good old active listening. We want to make sure that we're doing reflections and just kind of staying with them in that moment to make sure that we're really hearing and understanding their perceptions, what they're sharing. We're not moving too fast from that. And sometimes it's hard to just reflect or affirm, like, you really worked hard this past week, great job completing the measure. But also if the student's telling you something like, I've been feeling really worried for no reason lately, there are reflections that you can just provide for them so that they know that they have been heard. So that's what I mean when I say share. And I just want to be real concrete about that because we got some questions about that. All right, in terms of real measures, here's where I'm going to invite you to type in the chat measures that you use and that you like, because we want to crowdsource that for people so that you can see what one another are using. This is a great resource. If you've not been in here already, please go here to the Shape Screening and Assessment Library. It's a searchable library of free or low-cost screening and assessment measures. You can search on a lot of different criteria. You can download the measure right there, as well as scoring information. It is free to create a SHAPE account as an individual or as part of a school district or state. And then you just go to the screening and assessment tab. So please use this as a resource to go find new and different measures if you feel like you need, you know, a sharper toolbox or a bigger toolbox for that stuff. And for folks that are typing in measures, if you would for me, please spell it out, because some folks will be more familiar with your acronyms than others. So thanks for entering those in. I see Kimberly's using the DLA 20, for example. There's a lot of different considerations for measure selection. It's hard to get everything you need all in one measure. You know, I think we all know that our measures that are available in the literature, you know, none of them are perfect. None of them are perfect for what we need, but to find the best possible measure you can. So for example, if a student does not have English as a first language, that's a non-negotiable. You've got to find a measure that's in their home language, period, right? If this is a presenting concern that's happening a lot in the classroom, you've got to find something that has a teacher report, because the parent's just not going to be able to tell you everything that's going on in there. You know, you want to look at cost and things like that. So there's a lot of considerations here. Not all measures are created equal, but you want to use this to really think through, what do you need in a measure? I also will say that brief is really, really important. And when I say brief, I mean, I don't want to see questions on the back of the page. And probably even a full page of questions is too long. There are other longer assessments that you all may do at intervals throughout the school year that are longer, that are well validated, that are part of your assessment toolkit, that are fantastic. But when I'm talking about measurement-based care, I'm talking about something ultra brief that they can complete in a minute or less, and you can talk about right there. You can hand score and talk about right there. So a PHQ-9 or a GAD-7 or somebody's, you know, personalized kind of goal rating scale. SDQ short form if they're used to doing it. There are a lot of sort of brief, ultra brief measures. I've seen some measures as short as four questions that you can ask, some functioning based measures, something that's really brief that you can just use as a check-in basically, and then talk about it. So thanks for entering in your student progress measures. Please keep those coming. And then in our last couple of minutes here, I just want to say a couple words about data system options and implementation. You do not need an electronic data system to do measurement-based care, but it is really nice to see the graph right away. Also, students and families, students in particular, really like to enter the information in the computer and like see it populate. So I've had some clinicians tell me that they felt like the engagement with students was better if they could enter it in their, their own Chromebook or on their phone or with you. But just know that these data systems, they come at a cost, and that's really difficult for a lot of schools, but you don't have to have a fancy or expensive data system to do this practice. There's a brief here that you can look at that kind of goes over some of the considerations and questions you might want to ask data system developers. And this is my best list of the data systems that I know about. Google Forms is listed on the bottom, and we have had some school districts like New Bedford in Massachusetts actually has done awesome measurement-based care work, just really building out and using Google Forms. So if you want to like build it internally or use Google and do it in a free way and keep it confidential, just know that's happening. So there are some free ways that are going to be more effort on your part, and maybe you have like an awesome data team that can help you with that. Otherwise, you're probably looking at buying something. They vary in terms of price. The ones that are asterisked here are school specific, but know that there's other options for data systems that were created for like a clinic space that can be used by school providers. And in some of the projects I'm doing, we're actually using some of sort of the clinical healthcare measurement feedback systems that school clinicians have access to, and they can go in and do their login, and they're doing that for their students. So this is kind of a marketplace that's a little bit more built out on the healthcare side of things than in education, but we are seeing like BH Works for schools, Project Co-Vitality, those have both been developed specifically for schools. And then some people are customizing Power School or other sort of student information systems that you have for academics to have like a module or a component where the mental health data can go into it, and you can kind of restrict access for your behavioral health providers being able to see that information there. So if you have more questions about this, please hang on after the top of the hour and we can dive into some of these. And then in terms of planning ahead for training and support, I just want you to be mindful, and I'm sure you know this from experience, that just providing a training and setting people loose is not usually how most of us can change our everyday practice, especially in the context of all the time constraints and everything that folks have shared. So some of the work that I've done with my team has been to understand empirically from sort of multiple stakeholders across the country in schools, what are some of the top implementation strategies that are most important and most feasible in schools? And in our work, these are the 6 that have come up. So they might be ones for you to consider. So you might want to assess for some readiness first. Folks have told us that identifying and preparing champions, probably like those of you on the call right now, might be some champions who are embedded in the schools, can be very helpful for implementing MBC in schools. Developing a brief but usable implementation plan, like what measures do we think we're using, at what intervals, who's going to try it out first, when are our times to connect about this, and I'm happy to share sample implementation plans if that's useful to you. Making sure clinicians have measures. That's a big issue in schools. I mean, I just feel like a lot of times people are like, I don't even know what measures to use or what I need, or getting access. So giving kind of a menu of measures, making people sure access to measures can understand them is a big deal. Of course, providing access to training materials, but also really taking a critical look at the documentation overall, what expectations there are for documenting MBC, because the documentation issues, we don't want that to become sort of a barrier. And other ones that have come up have to do with ongoing consultation and training. So, long term, you probably would want to have implementation supports at multiple levels, just like anything else you're implementing. We're talking a lot right now about the school mental health clinician level, but if you're really thinking about this practice being implemented long-term with sustainability, we have to attend to strategies to support implementation at all levels of the system. So we shouldn't just be sort of passing the baton to clinicians, so to speak, and saying, okay, this is your thing to do now. There should be different types of supports at kind of our education and mental health system levels, as well as our school and school partner organizations who are wrapping around supporting and overseeing clinicians, as well as thinking about how can we make this feasible for students and families to engage? What are the implementation supports that are useful for our students and families? I always recommend just like also asking, especially if you're starting with clinicians, ask clinicians what's most helpful, ask them what they need. These are just snapshot data from program evaluation that we did on a big implementation of measurement-based care in schools. And you know what clinicians told us that they liked the most, what was the most helpful, was what's on top, talking to each other, talking to fellow clinicians and supervisors. That was the most helpful for them in understanding how to integrate this practice in their work, and having it as part of regular staff meetings and supervision. Of course they needed initial and follow-up training. We're not going to not provide training, but asking people what's most helpful and using those feedback loops to get folks what they need can be really helpful. So here are my bite-sized take homes of things like what could you do between now and the next couple of weeks in your busy schedule to get this started. You could, of course, share this presentation in part 1 with your colleagues, talk to a couple folks that are most interested in this practice, get some ideas on how to get started. You might want to start by piloting a couple of measures or use a trial period. Some of these feedback systems you can purchase, like the trial period for like 30 or 60 days. Ask people about that. How can you try it out before investing in it? Talk to parents, find out about parent and student interest and questions and recommendations. Here's the link to the screening and assessment library if you just need to get your hands on some measures. You can check out the YMBCC website if you want to know more, especially about Collect, Share, Act. There's a lot of goodies on there. And then you could also check out a couple demonstration videos by yours truly showing how to do this practice. So here are just some bite-sized ways to get started. And so with that, I do want to hand it back over to Tara.